planning biomechanics for impacted canines using CBCT integration. So let's welcome Sandra.
Thank you so much. Thank you. Well, everyone, it's great to be here in Orlando, AAO 2026. And who would have thought that we made it here? And it didn't occur to me, I had packed all my clothing before I came, but yesterday I spent the day at the Magic Kingdom, and I realized that this color scheme was dressed just like everyone else at the Magic Kingdom. Today I want to take you out of your comfort zone, because if you've been here since 8 o'clock this morning, we learned a lot about aligners, biomechanics, material science, attachment design, staging the treatment in stages. But in our mind, there's always a scope of cases that we're comfortable treating with aligners. And that's going to be different for you as it is different for me. And as our clinical experience increases, we almost always enlarge the scope of types of malocclusions we're going to treat with aligners. But today I really want to take you out of your comfort zone because the theme for Orlando, any of you know the theme? Beyond possible. Can you all say it together with me? Beyond possible. One more time. Let's wake up, everybody. Beyond possible. That's where I want to take you. So I think many of you know who I am. I'm from Vancouver, Canada. I'm a clinical assistant professor at 3 different universities, at the University of British Columbia in Vancouver, University of the Pacific in San Francisco, and most recently appointed to University of Pennsylvania in Philadelphia. I think I'm most well known for being the author of Clear Aligner Technique. I've also authored a chapter on clear aligner treatment in Graeber's orthodontics. So I do have a disclaimer and a conflict of interest disclosure. I'm a member of the Align North America Advisory Board and Align Tech Global Faculty, and I also receive royalties from only the English and Spanish translations of Clear Aligner Technique, even though the book, the first edition is in 13 languages, the second edition is already in 3 languages. So the next slide I want to show you is welcome to Vancouver AAO 2027. Please sign up now. There's a desk downstairs. I welcome you to my beautiful city. This is downtown Vancouver. The convention center is right on the waterfront. You'll be right by the ocean and in the mountains. There'll be beautiful places to visit pre or post conference in Whistler, British Columbia in the mountains, or you can take a ferry and visit Victoria on Vancouver Island. So what are we going to learn in the next 45 minutes? We're going to talk about what biomechanics we're going to employ to align impacted canines with aligners, how to set up a CBCT integrated digital treatment plan for impacted canine cases, when to use auxiliary techniques for impacted canines. Very simple, 3 laid out clear objectives. But first of all, let's lay a little bit of groundwork on the classification, the severity and treatment difficulty of impacted canines. And rather than referencing a very old publication, I decided to look for some of the more recent publications. This one is in 2022. Basically, we're looking at crown position. The closer the crown is to the ideal position, the easier it is going to be to align it. And the more mesially directed or towards the midline, the more difficult that impaction is going to be. Then we're going to look at the root position. Ideally, the apex of that impacted tooth should be where it would normally be, with just a crown displacement. So if you look at this, that's going to be easy. The apex is exactly where it should be. But if the apex gets displaced, and the more displaced the apex is, the more difficult it is going to be to bring that tooth into alignment. The third one is the height of the crown. Where is the crown in relation to the occlusal plane? And of course, the more apically displaced that crown is, the more difficult it is going to be and the longer it will take to bring it into the mouth. Now, the conclusion of this review said males were found to have higher impactment difficulty in maxillary canine impaction than females. How interesting. And the severity of palatally impacted canines is greater than buccal impaction. I think that's not a surprise to most of us. So let's look at our first case. If you've never treated an impacted canine before, this is a great case to start. There's no vertical problem. The overjet is normal. There's no sagittal problem. The patient is class 1. Now, she is in late mixed dentition, and you can see she has retained and partially submerged primary second molars and a retained upper right primary canine. Now, this is her panoramic radiograph, and clearly we can see an impaction here with root resorption on the lateral. The crown is quite apical. The apex is where it should normally be. And on the right side, this is also mildly impacted. So the first digital treatment plan is going to focus on opening spaces for the impacted canines and diverging the roots of the lateral incisors to create an eruption path. Now, the attachments on the primary molars that are submerged. Why? Because when the patient takes the aligners in and out every day, I would like to encourage exfoliation of these primary second molars so that we can transition more quickly into the full permanent dentition. And there are only 21 initial stages because that's all my treatment goal is. Now, at 21 aligners or 5 months, you can see here that in the lower arch, we've transitioned into the full permanent dentition. There's some great leeway spaces. The upper right canine, the cusp tip is actually now starting to erupt. So when we create that eruption path, when we open up enough space, when we diverge the roots, guess what's happened? Some of these impactions will self-correct and they will erupt. Of course, we're not going to be as fortunate on the upper left side, so here's where we refer the patient for surgical exposure. And there's lots of leeway space. In my mind, an aligner is one of the best lingual holding arches ever. And we're going to use that leeway space for alignment and to retract our lower incisors. So now we take a CBCT before surgical referral. And here you can see actually on the side that self-corrected, there was some resorption of that distal of the lateral incisor. On this side, that's not good news. Here the image is reversed. So this is the upper right, and this is the upper left, and you can even see some resorption on the very apical tip of the central incisor. So now we're going to refer for surgical exposure, and on the buccal, we normally do a closed exposure, and that's going to be a gold chain that's going to be hanging out from the gingival margin when the patient comes back from the surgeon. Now, based on the CBCT, and you know it's overlapping with the root of the lateral, the first thing we want to do is distance this tooth away from the lateral incisor. So we're going to retract it buccally to a chain on a button cutout on the molar. So we're going to either loop a chain or tie a power thread. So the first thing we want to do is distal, but of course, since the molar is on the occlusal plane, there's going to be a distal occlusal force. And once the tooth has erupted, the second thing we're going to do is now we're going to bond another button on the lingual and wear basically an extrusive or bootstrap elastic to erupt this canine into the eruption compensation. So here we are, we're at 22 months. This is an eruption compensation. That tooth has continued to erupt. And the eruption compensation will actually guide that tooth to erupt into place. And on this side, this is also an eruption compensation. And now this is our final additional aligner order. We're going to include the erupted canines. Now the attachment on the upper left tooth was not bonded due to the resorbed root. I was very concerned about losing more root length on that tooth. But if you've been in this room since 8 o'clock, what would be the impact of not bonding that attachment? That extrusion probably will not express. In the upper arch, which is in full permanent dentition, we're just going to do our final detailing and alignment. So here we are at 35 months. This is the post-treatment records. Look pretty good from the anterior, but from the buccal, we can see the lack of extrusion of that lateral incisor. I spoke to the parents and I said, you know what? I think we're good for now. It's more important to have a root on that tooth than to really sock it into occlusion. And we're at 35 months. We're done. Here we are. Here's the post-treatment panoramic radiograph. This root looks pretty stable, and this one looks very similar to the pre-treatment root length. We bonded an upper 2-to-2 wire, placed the patient into upper-lower viveras. In 1 year, the occlusion has settled. So where there was an open bite, the occlusion has settled well, 1 year post-treatment. And here we go. Now let's look at another case. This one is a class 1 bimaxillary protrusion malocclusion, impacted canines. You can see here the proclination of the upper incisors severely proclined. The canines are impacted, and there's moderate crowding in the lower arch. On the cephalometric radiograph, we can see that the patient is class 1 bimaxillary protrusion. These are the impacted canines on a panoramic. Now I want you to look carefully because this is going to be radically different from what you see on the CBCT. So for those of you who don't have a CBCT in your office, previously I didn't have one, there were certain types of malocclusions I would refer out for CBCT. Impacted canines was number 1 on the list, surgical cases was number 2 on the list. And now, you know, many aligner companies have the ability for you to upload your DICOM file and integrate that into the virtual digital plan. And when the aligner companies went to this step, that's when I actually invested in a CBCT machine in my office so that I could integrate every digital plan with CBCT integration. So this is the CBCT, and you can see it looks really different in terms of how much root there is left on the central incisor. These red markings were not drawn by me. They were drawn by the oral surgeon who sent them back to me. And I always say, sometimes it's not up to the orthodontist whether you can save the tooth or not. Sometimes the oral surgeon gets the final say. He said to me, Sandy, these teeth are mobile. There's no hope. We're going to extract the centrals. And your job is to bring the canines in. Well, that's interesting, isn't it? What a tough job it's going to be. So I have a diagnosis and I have a treatment plan. My diagnosis, class 1, bimaxillary protrusion malocclusion, increased overjet 4 millimeters, normal overbite, severely proclined maxillary incisors, impacted canines, severe root resorption on the central incisors, minor lower arch crowding, class 1 skeletal pattern. So what's my treatment plan? Extract the maxillary central incisors. We're going to surgically expose and bring those impacted canines in to substitute for the central incisors. We're also going to extract mandibular first premolars because the patient is bimax protrusive so that we can finish class 1 molars, and then post-orthodontic restorative treatment for the central incisors. So here we go. Now the first series of aligners, initial aligners distalize the maxillary lateral incisors away from the impacted canines. We don't want to endanger those teeth. And then at stage 16, we extracted the centrals. We put in this huge pontics because the canines were coming in diagonally. So you cannot have pontics exactly the same size as the canine. That's clue number 1. Make a pontic larger because these canines come in diagonal, they come in rotated. In the lower arch, we extract it, and then we close a space. Now the lower second premolars are eruption compensations, and that's what they look like. So now we have to think creatively. How do we bring these canines into the intraoral cavity when I only have pontics on my aligners? So on the labial, we do a closed exposure. Gold chain will be hanging down from these 2 teeth when the patient comes back from the surgeon. We'll loop a power thread through the gold chain. And in this case, you can see that I've made precision cuts with a plier, with J. Bowman's Hue 3D pliers. And then the patient puts the aligner in, pulls the power thread up and over into the precision cuts to engage it. And after many, many months, here we are. Our lower extraction site spaces is almost closed. We still have a significant curve of speed, so we're going to have to level out that occlusal plane. But my canines are in the mouth. Take a progress panoramic, check where the roots are. Roots will need some detailing and finishing. Many aligners later, here we are. This is the final pre-restorative and final panoramic CBCT. So let's look at palatal. We've looked at two types of buccally impacted canines. Looks like a palatal impacted canine. Again, if you've never treated an impacted canine with aligners, this is a great case to start. You don't have an AP discrepancy to deal with. You don't have a vertical discrepancy to deal with, but there is a retained primary canine. And on the panoramic, you can see where the location is. Where's the apex of the tooth? Right where it should be, but it's very high up. The crown is overlapping the central incisor, so it's fairly solid towards the midline. That's why they say palatal impactions are more difficult. This is one of my favorite views. It helps you visualize where that tooth is on the lingual. And here, I know it looks bad, but this is the primary canine here. So the primary canine was extracted, and the surgical exposure was performed before the aligners were inserted, so that immediately upon insertion of the aligners, we can start applying traction to the tooth. Now, this is a huge difference between treating these cases with fixed appliances, where we have to slowly work our way up to a stainless steel rectangular wire before we can do the surgical exposure. And here you can see we're just opening up space, diverging the roots, and that's what the first 25 aligners are for. Now, all these cases will be submitted as a 5-year comprehensive unlimited aligners, because my goal is not to wear all the aligners till the end. My goal is to rescan as soon as I think the canine has erupted enough for me to engage aligners over it. So how did we bring palatally impacted canines in? On the palate, we always do open exposures. And here we have an eyelet on the canine and an eyelet on the premolar with a button cutout, and we just tied a power thread. It's not that difficult, right? And when we think about the biomechanics, we have a button cutout here for the eyelet, right? And here I overlaid the digital treatment plan at a certain stage on top of what it looked like intraorally. So first of all, we need to rotate that canine mesial out, and then we need to move it buccally. And the direction of pull of the power thread, right, actually helped us to correct that rotation very nicely. In fact, the tooth moved faster than I could open up space for it. So at a certain stage, we're going to rescan, we're going to capture that erupted canine into my aligners. You can see I've put an attachment on it. And the additional aligner order, we're going to do expansion, upper molar distalization to create more space, and then start moving that canine to the buccal. And you'll notice there's actually space mesial and distal of that canine as we start moving it to the buccal. And eventually we will close up the space. I really like Dr. Roberto Carrillo's philosophy on what he called batch treatment. That means just rescan after every few aligners so that you know. So in this case, the final is not set up to ideal. It's going to have spaces, mesial and distal of the canine, so that I can move that canine in. I can correct any rotated canines. Let's look at another case, more complex this time. She's 13 years old. She's a little bit class 2, so now we have an AP discrepancy, and we have an impacted canine. Now, this impacted canine is a little different. Well, first of all, what's good is the apex of this tooth is exactly where it should be, but the crown here, you can see, is wedged directly behind the central and the lateral incisor. That's what they call a sticky wicket. What are we going to do about that? How are we going to manage this discreetly so that we don't endanger the health of the adjacent teeth? So in this case, we did CBCT integration. And you can see here, she's smile class 2. Here's the canine. You can visualize where the apex is and where the crown is wedged between the central and the lateral. And the lateral is grayed out because we've decided to make that tooth immovable. I feel like any movement I make to the root of that lateral is going to run it right into the impacted tooth. So I have an eruption compensation. We're doing some minor distalization to open up space. Now here you see in the final stages, the incisors are almost retracted against that impacted canine, but we're not going to wear the aligners all the way, right? I expect to be distalizing my canine as the teeth move. There's minimal movement in the lower arch. So here, this is how we can plan the biomechanics. I take a screenshot from my digital treatment plan just to help you explain. First of all, we're going to distalize that impacted tooth. So the first direction of pull I'm going to pull is distal, not buccal, distal. I need to dislodge this canine away from the central and the lateral incisor. And you can see here, I've actually put a button cutout on my molar in anticipation of the direction in which I'm going to run the biomechanics. The eruption compensation is much larger than the contralateral canine. We want a larger space than the actual mesiodistal width of the tooth. The lateral incisor here is gray. It's made immovable because anything I do, if you put a bracket on it, it's going to turn around, the root will tip right into the impacted tooth. So for the first series of aligners, I'm going to make this lateral incisor immovable, and I have bite ramps to exclude the occlusion, because at some point I have to move this canine from the palatal to the buccal, and I need the occlusion discluded. So having planned that, here's the clinical execution. And this is how we would clinically execute that planning. We have our button cut out, we have a button on the lingual of the molar, we have an elastomeric chain from the canine to the molar to distalize it away from the lateral incisor. You can see the bite ramps. The eruption compensation has been filled with a tooth-colored pontic material, so it's very aesthetic for the patient. And then the plan is as when the canine distalized enough and it's directly lingual to that eruption compensation, we would make a button cutout and then start the buccal traction. So first, distalize away from the central and lateral, and then when it got to a certain point, we would start moving it buccally. So pre-treatment progress, 5 months later, the ClinCheck plan had 25 or 26 aligners. Here we are. Now, of course, we tipped the tooth. Where was the apex? Exactly where it needed to be. What did I need to do? Tip the crown to match the apex. And by tipping the crown to match the apex, the labial surface exposed. So at this point, I'm going to take a scan, and I'm going to try to get my aligner to engage onto this newly surgically exposed canine. Sometimes you hold your breath and you think, will they put it in the aligner? Yes, they did. They put it in the aligner instead of giving me an eruption compensation. Here we see actually there's very few active aligners in the upper arch, right here. From stage 18 to 57, only the upper right 2 and the upper right 3 are moving. So what did we do? We opened up a larger space. We didn't try to complicate things. We moved the canine buccally, and then we started to derotate. And when we felt there was enough distance, then we started to move the lateral incisor into place to complete the movement. Here's another case. This is an impacted central incisor. I don't have enough time to show you the actual case, but I wanted to give you some ideas. With CBCT integration, here's the central incisor in the bone. Ask the surgeon to place the button and the chain on the lingual. And the pontic here is very small, but this is stage 1 of the digital treatment plan. It will continue to open, but we've already made our precision cuts. And then we're going to loop an elastomeric thread and loop it over the eruption compensation to bring the central incisor into place. All right, let's talk about designing the CBCT integrated plan for the impacted canines. Now, here's a digital treatment plan. You can see upper molar sequential distalization being programmed to make space. Now, watch the root of the lateral. No go, right? This is the first plan that comes back. From the occlusal view, you can see distalization, correction of the rotation of those first premolars that are normally 2-rooted. But look at the root of the lateral. the software automatically corrects the angulation of the root and runs it into the impacted canine. So what am I going to do? I'm going to modify the treatment plan, right? I'm going to hit modify, and I'm going to pull up my 3D controls, and I can see that they've added 8.9 degrees, or almost 9 degrees of distal root tip to this lateral incisor. So I select the lateral incisor and I reverse all that distal root tip. I bring it back to 0. Essentially, I'm not going to move this lateral incisor. I need to diverge the roots away from the impacted canine to create that eruption path. So when you're designing your CBCT integrated plan for the impacted canine, number one, first priority, open a space. Open a slightly larger space than the actual mesiodistal width of the impacted tooth. And I would normally ask for 10 millimeters of eruption width. Now this is the initial width. You can measure this. And in this digital plan, they only gave me 8.5. I wish I asked for 10. You can see that I made more in the additional aligner plan, but I could have asked for 10 from the beginning. Number two, diverge the roots of the maxillolateral incisor away from the impacted tooth to create an eruption path. If you were treating this case with fixed appliances, how are you going to bond that bracket on the lateral incisor? Chances are we don't think too hard about it. You would just ideally bond that bracket on your lateral, not knowing that there's distal root tip built into that bracket. So if you're treating cases like this with fixed appliances, make sure you bond the bracket to create that mesial root tip, and you can always reposition that bracket after the canine has erupted intraorally. Now in this case, this is the beauty of CBCT integration. Look at this premolar root. It's a little bit of a dilacerated. That could have partially caused the impaction. So that tooth may not look very aligned in my digital treatment plan, but I'm definitely going to diverge that root away from the canine to create an eruption path. Now, sometimes, as you saw in the previous case, the maxillolateral incisor in close proximity to the impacted tooth could be made immovable in your first series of aligners. You don't need to move that tooth until you have distanced the impacted tooth away from that lateral incisor. And finally, in class 2 cases, you can program in some maximolar distalization that can be performed to create space for canine eruption. And in this case, not only did we distalize, but you can see we did a mesial out rotation. And sometimes these two-rooted first premolars are kind of tricky, and you cannot visualize it very well on a panoramic radiograph. You can't control it very well by putting a bracket on it, but you can see it very clearly in the CBCT integrated treatment plan. So how did that case turn out? Just to give you a glimpse, pre-treatment, at 5 months, the impacted canine erupted spontaneously. Why? We opened space, we diverged roots, we created an eruption path, and that canine corrected and self-erupted. So here's a summary. If you want to take a picture, this is a slide. Designing the CBCT integrated plan. Open up a slightly larger space, ask for 10 millimeters. Diverge the roots of the maxillolateral incisors away from the impacted tooth to create an eruption path. Sometimes the maxillolateral incisor may be made immovable, and in class 2 cases, maximolar distalization may be performed to create that space for canine eruption. Right, let's up the ante a little bit. So far we've been looking at class 1. Let's look at class 2 impacted canine cases. This young lady came, she's in late mixed dentition. She has been edentulous in these sites for a while, because I think her dentist said, well, your canines are not coming in, let's do an early extraction of the primary canines, and nothing happened, and nothing happened. She went to 3 other orthodontists who says, no, there's no way you can have aligners because you have 2 impacted canines. But she's an actress. She said, I can't have fixed braces on my teeth. I'm filming, I'm going for auditions all the time. And finally, her dentist said, I know you have to drive across town, but can you go see Dr. Sandra Tai? That's a way to do it, she'll find it. And I said, sure, no problem. We kind of do these things routinely. You can see the upper right is not badly impacted. It's severely rotated. This one is more impacted. The upper right is in the line of the arch, but the upper left is on the lingual. So now I have a diagnosis, and I have some treatment objectives. And I'd like to approach this systematically, right? Skeletal, class 1 hypodivergent, soft tissue, orthognathic facial profile, normal lip posture, but dentally, she's class 2 in late mixed dentition. Dental midlines are coincident, minor crowding. So what are my treatment objectives? For skeletal, no growth modification. Patient is skeletal class 1. For soft tissue facial, the lip posture and facial profile is normal, so no soft tissue improvement is planned. For dental, of course, now here's where the work goes. Correct the class 1 molar and canine, correct the deep bite, decrease the overjet, align the impacted canines. So now we're going to transfer that treatment plan into the digital aligner world, right? Because that's what I'm going to program into the digital treatment plan. How am I going to get from class 2 to class 1 if I'm not planning skeletal growth modification, upper molar sequential distalization? My vertical protocol, I'm going to correct the deep bite through upper and lower intrusion and posterior extrusion, a combination of both. In the upper arch, I'm going to create space for the canines through expansion, allow the upper incisors to procline a little bit, and then correct the deep bite by incisor protrusion, intrusion, and posterior extrusion. In the lower arch, we're just going to align the lower arch primarily through expansion and try to avoid proclining the lower incisors. And we have a retention plan. And to retain with upper and lower Vivera retainers with bite ramps. So here's the digital treatment plan. Here's a normal overbite overjet. Here's the tooth. And here's the other side. And not only does the CBCT show unerupted teeth and impacted teeth, so it's very useful for us to plan. You can see on the upper right, it's in the line of the arch. On the upper left, it's more on the palatal. So the first series of aligners is going to focus on creating space. We're going to create that space by distalizing the teeth. And you notice I'm going to maintain that mesial root tip of the maxillolateral incisors. On the occlusal view, you can see we're going to distalize, open space, maintain that mesial root tip of the maxillolateral incisors. Now, it's very interesting. I see this patient, first appointment back after aligner insertion was 12 weeks. At week 10, mom sends me an email. You know she's a stage mom, right? So we're in constant contact. Dr. Tai, the canine on the upper right side has erupted. We haven't even been back to your office for a single appointment beyond receiving the aligners. How did that happen? We opened space. We diverged the roots. We created an eruption path, and that too spontaneously erupted. And I said, that's great news, but please keep your appointment with the oral surgeon because you're still going to need that surgical exposure on the upper left. So when we're planning the biomechanics, what are we going to do? First priority, open space for canine eruption, diverge the roots of the lateral incisors, and first premolars to create that eruption path. So you can see we're going to open space, we're going to diverge the roots, we're going to maintain that mesial root tip in the treatment plan. And then, on the upper right 3, the plan was to surgically expose and then retract distally. Probably we could use it with a class 2 elastic. But that too spontaneously erupted, so we didn't have to do that. On the upper left side, the first plan after we opened space was to move this tooth buccally and then eventually erupt it into the eruption compensation. So here we are at 7 months. At 7 months, as I said, the upper right 3 erupted. So it was a little bit buccal, so we had to trim the eruption compensation to allow it to erupt more. On the upper left side, we have the gold chain. We have a clear power thread here that's going to be looped to the labial of the eruption compensation to move this tooth into the line of the arch. At 9 months now, you can see both canines are erupted. In the lower arch, we have an exfoliation, great leeway space that will give me some space to correct the rotation, correct my lower incisor inclination, because she started off class 2. And here we take another scan, and now we can include both canines into the digital treatment plan. Doesn't look like a difficult movement at all for the aligners. In the lower arch, we're going to use the leeway space to mesialize the lower first molars into a solid class 1 relationship. And that's going to be aided with class 2 elastics. So here we are at 22 months. I think these are her most recent records. She's transitioned into full permanent dentition with leeway spaces. Her smile looks great. She's got upper canines in place. Now, if you Google this patient, this is what's going to come up on your Google search. What do you notice about these photographs? She plays the teenage kid in every Hallmark movie. Vancouver is also Hollywood North. So most of the Hallmark movies and the movies on the Women's Network are filmed in Vancouver. She's the rebellious teenage daughter in all the movies. What do you notice about these photos? Not smiling. Someone had extracted her primary canines. Whenever she smiled, she had those gaps. She was very, very self-conscious. And I can't tell you that I'm waiting for her to update these photos online to show her new smile. We're not quite done yet, but already she can enjoy that smile. And I want to remind all of us, we are in the noble profession, you know? We talk a lot about systematic reviews and evidence-based orthodontics, but let's not forget, at the end of it, what are we doing? When we change a smile, we change a life. Throughout our career lifetime, we have the ability to change hundreds, if not thousands, of lives. And I think that's one of the most rewarding parts of being an orthodontist. Many of you have seen this transformation. They come in, they don't smile for the initial photos, they don't talk a lot, and when you take the post-treatment photos, they're grinning from ear to ear, you can't stop them from talking, they're just completely transformed. Right, so in our last case, I really want to push the limits of the comfort zone. Here's a 13-year-old male, Class 2, Division 2, 100% deep bite. So now we have an AP discrepancy, full cusp Class 2. We have a vertical discrepancy, 100% deep bite. We've got some moderate crowding issues. And this is the extracted pen and ceph from the CBCT. Wow, right? I think many of you who have heard me before, you know I'm a great advocate for early interceptive treatment. And my staff kept running in and said, Dr. Tai, I know you did a new patient consult, but we actually saw this patient 4 years ago. I said, really? Yes, we have a pan on file. 4 years ago, patient had a deep bite, and we recommended early interceptive treatment. Now, one of our goals of early interceptive treatment would have been to open space. And if you and I were betting, we would have bet on that lower left, but actually the lower right impaction looks much more severe than the lower left. And I can't help thinking of the many cases I've treated in the past where an eruption path managed to self-correct when we made the space, diverged the roots, and allowed that tooth to come in. Now, this is a different patient, pre and post, after phase 1 treatment, and you can see that eruption path was a little mesioangular. So how can we encourage canine eruption in an early interceptive treatment? Number 1, arch expansion, oldest trick in the book. You can expand it in many different ways, both upper and lower. Don't forget, your lower canine could be impacted as well. And what we normally do at the end of an early interceptive treatment is to make sure that we've opened up spaces, mesial and distal, of the primary canines in all 4 quadrants. That's going to accommodate the morphology and the width of the permanent canines. And then finally, at the end of every early interceptive treatment, we always add that mesial root tip to the adjacent permanent teeth. So if you're doing 2x4s, please pay some attention to the bracket position on your maxillary lateral incisors. I don't think it's as critical in the lower, but definitely in the upper arch. And if you're using aligners, just build that mesial root tip into your digital treatment plan. When I'm using Invisalign first, the algorithm for early interceptive treatment is actually very good, but I always go in there and I add that mesial root tip to my maxillolateral incisors before I approve the aligner. So encouraging canine eruption in early interceptive treatment. Unfortunately, we didn't have the opportunity for this patient, so now we're back to our diagnosis and our treatment plan. Class 2, hypodivergent skeletal pattern, convex profile, mandibular retrognathia, and then dentally, Class 2, Division 2 in late mixed dentition, 100% deep bite, primary second molar still present, mandibular primary canines are retained, lower arch crowding, and impacted lower canines. So what are my treatment objectives? Skeletal growth modification. Here I have a growing patient with a retrognathic profile and a Class 2 skeletal pattern. I'm going to attempt growth modification. I'm going to improve the soft tissue profile and increase the chin projection. And dentally, we want to correct to Class 1 molar and canine, correct the deep bite, and bring those impacted canines into alignment. So how am I going to do that? How am I going to get from Class 2 to Class 1? Well, we're going to do it with Invisalign, with mandibular advancement, with the precision wings. This was before the days of occlusal blocks. We're going to correct the deep bite through upper and lower end intrusion, but the patient is also hypodivergent, so I'm going to allow some posterior extrusion to help the deep bite correction. In the upper arch, incisor intrusion, posterior extrusion. Class 2, Division 2, so I'm going to use the procline, intrude, retract protocol on my upper incisors. And because this is a precision wing case, we're going to ask for a pre-mandibular advancement phase to allow us to address some of these issues in the deep bite before we start advancing the mandible. In the lower arch, we're going to align the lower arch primarily through expansion, surgical exposure, and alignment of the impacted canines, and then a retention plan, upper and lower vivera retainers with bite ramps. So here is my digital treatment plan. You can see here we have a pre-MA phase, and this pre-MA phase is to allow us to address the deep bite to a certain degree, procline, intrude, retract protocol for the upper incisors. The mandible advance in a series of stages into an edge-to-edge position. So here we are at 5 months. This is exactly the same photograph with and without aligners intraorally. I have buttons on my premolars and a power thread from the gold chain to the button, as you can see illustrated by the yellow lines here. And in the lower, you can see the precision wings that posture the mandible forward. At 9 months, we had completed the advancement phase. And how have we measured up against our treatment objectives? Soft tissue profile, improved facial profile, increased chin projection. Yep, check. AP protocol, corrected Class 1 canine and molar. Check, my molars are Class 1. Vertical protocol, my deep bite was only corrected 50%. We learned that it is a less predictable movement. So what do? Make additional aligners, do more of the same. Keep addressing the deep bite, right? And my upper incisors still need lingual root torque, so more lingual root torque in the next series of additional aligners. And my canines are still impacted, but the lower right one has erupted. So we take a progress CBCT, and you can see that in 9 months, that lower right canine looks pretty on track. This one has uprighted significantly, but the crown is still very close to the midline. Lots more work to be done on the lower left. So when I program in my additional aligner, and that's one thing about doing aligner treatment, we're always re-evaluating our treatment goals. How far have we come? Where do I need to go next? So what are my additional aligner objectives? Now I'm going to do upper molar sequential distalization just to complete the correction to Class 1. It's going to help me because I need to torque my upper incisors forward. Vertical protocol, continue to level the curve of speed through upper and lower anterior intrusion and allow the posterior teeth to erupt. Upper arch, improve upper incisor torque, procline, intrude, and retract again. And in the lower arch, continue to create space for those impacted canines to come in. So here we are at 17 months. And now we have transitioned into the full permanent dentition, lots of leeway space, and I'm going to retract this into the leeway space to make space for that canine You can see the power thread here. We unhooked it to take pictures. And here's something interesting, right? Look at the torque on those lower laterals. On the CBCT, the impacted canines were labial. So what did I do in my digital treatment plan? I maintained that lingual root torque. I'm not going to allow those roots to come forward until the canine, because the canine is buccal and the other one is also buccal, I'm going to maintain that lingual root torque, position my canines, and then in the detailing and finishing, I can add buccal root torque to those lower incisors again. So this is at 22 months. And these are my most recent progress photographs. My estimate is probably going to take me 3.5 years to bring those impacted canines in. These were very severe cases. So what are our keys for impacted canine cases? Labial is easier than palatal. Consider using buttons and elastomeric chains to upper molars to retract the exposed canine, either on the buccal or on the lingual, and then you can use extrusive elastics to erupt it into an eruption compensation. I've heard many other speakers use TADs. I haven't had to do that because I'm doing simultaneous aligner movement. And some severe cases, you can always expedite the treatment a little bit by putting on segmental brackets as an adjunct where there are severe rotations or severe root inclinations. Last year in Seminars in Orthodontics, I published an article called Transforming Lives. And in that article, I said, as an educator, a speaker, and a teacher, my role is not only to offer the evidence in the scientific literature for how aligners work, but today it was more about demonstrating clinical protocols that could be implemented, but always communicating the passion we have for changing the lives of our patients through transforming their smiles. My invitation to you today is to join me in this journey of transformation. Thank you very much. Do we have any questions?